All right, guys, so we're moving into video 3 of our traumatic brain injury, stroke, and seizure brain day talks. Doing this in a couple different formats. If you're watching all 3 of these going all the way through, I apologize for a little bit of repetition here. If you're watching these bit by bit or one at a time as a one-off, that's fine too. But this next video is going to cover seizure, and it's going to be fairly short. Mostly BLS, like the other 2 sections have been entirely BLS discussions, but there will be a little bit of ALS when we talk about anti-epileptic medications. But I want to make sure that we're thinking about seizure at all levels of providers, because really BLS care, good BLS supportive care for seizure is all that most of our seizure patients really end up needing, which is pretty cool. Another quick caveat, sorry if this is the third time you heard this in the video, but this is intended for North Metro, Lafayette, and Pleasant View agencies that I supervise. If you're watching this and you're not in one of those agencies and not under my medical direction, then this is just educational, informational. Thanks for watching, and I appreciate it. But you have to follow your training, local protocols, guidelines, medical direction, agency SOP, SOGs. Happy that you're watching it, but make sure you're doing what your medical director tells you need to do. So again, our learning goals, we covered stroke and traumatic brain injury in the 2 other videos, or earlier in the longer video if you're watching it. We're going to talk about seizure here. I want to cover a little bit on the mechanism of seizure, and then I want to cover a BLS approach to seizure with a little bit of, we'll talk about midazolam at the end there. So what are we going to talk about here? It's really about GABA. And GABA is a neurotransmitter. It's one of the most common neurotransmitters in the brain. What's interesting about it is it's an inhibitory neurotransmitter. And what do I mean by that? I mean that if we have 2 neurons that are talking to each other, usually when we learn about this in a basic way, we always think of the one neuron stimulating the next neuron and increasing the likelihood that next neuron is going to fire. GABA is weird because it basically jumps in and attaches to neurons, and when the neuron fires and releases GABA, it reduces the likelihood that next neuron is going to fire. So it really acts to slow down neurotransmission generally in the brain and in circuits in the brain, and it also tends to be like brakes in the brain, because if every neuron in the brain was activating the next neurons it touched, then we'd have a feed-forward loop, and we would basically have one neuron that's connecting to another and turning it on, that's connecting to another and turning it on, and we know that all of these systems talk back to each other, so eventually we're going to have feedback, and this is going to be like the microphone at a concert that's basically feedback and screaming, and that's what happens in the brain, which, by the way, is a lot like what's happening when you have a seizure, where you get this overactivation. So what GABA neurons do is, rather than having these red neurons that are basically stimulating the next ones, is they would be in a situation where if they're activated, they're going to affect another neuron and slow it down. So if we throw a couple of GABA neurons in here to see that stimulation, but then slow it down, it's going to act as brakes on the system, and it's going to keep that system from going into a feed-forward loop where it, or a feedback loop where it basically gets overstimulated and burns out. And so, why is it that people are going to seize? And so there's 2 things that can make somebody have a seizure. And one of those, it's either overactivation of the neurons or loss of that GABA suppression that's basically slowing everything down. So first off, seizure is the endpoint of a sick brain in a sick person. So a patient having STEMI can go into VFib, same concept, that the myocardium gets very irritated and excitable when it gets ischemic, and they tend to go into ventricular fibrillation, which is again these multiple feedback loops that are running in the heart, basically making it have disorganized activity. Stimulants can certainly cause seizure in massive overdose. Kind of uncommon. It's pretty rare to see someone without a seizure problem have a real actual seizure on meth or cocaine, but certainly it's possible. Certainly patients who are maybe smuggling it inside their body and they have a balloon of it break open. Seizure is very common in that with the massive overdoses, but the recreational doses, it's kind of rare unless they already have a seizure problem. The other big thing, and this is the most common thing, is withdrawal from other GABA activating stuff. So if I have a patient who's constantly drinking alcohol, abusing benzodiazepines, or just being prescribed benzodiazepines or barbiturates, if those go away, because all of those activate that GABA receptor and are suppressing activity within the brain. Those are all depressants. Then when you take that away, you can have seizure because now you've taken away this thing the brain's gotten used to having, the slowing things down. And then also the other thing that causes overactivation is things like irritating structural stuff, infection in the brain, brain abscesses, encephalitis, scarring in the brain from old strokes or old injuries, active bleeding in the brain, the blood is very inflammatory, or brain tumors are very inflammatory. All those things can cause seizures. So what are we going to do here? You know, we're the pre-hospital heroes here. We're coming in. And really, unfortunately, not much is what we're going to do for seizures. Because vast majority of seizures are self-resolving, which is cool. And if they're not self-resolving, we call them status epilepticus. So the things that we're going to actively intervene on with medications are going to be status epilepticus, which is a small fraction of our seizures. But what we're going to do for all these seizures is give supportive care, because we're going to prevent further harm. We're going to keep this patient from getting injured. Certainly, especially if we're coming upon these patients and we're off duty, we actually know what to do, and we can prevent these patients from having, helpful bystanders do unhelpful things. We can give them oxygen. We already talked about in the traumatic brain injury talk about how, sick and injured brain doesn't like hypoxia. So we can provide oxygen, supportive care for them. Get a good history and scene info. Do they have a history of seizure? Is this their first one? What medications are they on? And not just what are they on, but are any of those medications new? Or have they recently stopped any medications? Same thing with drugs. Not only what are they on, but is there anything they stopped doing recently? Could this be withdrawal? Very, very important history to get. And then trauma or medical issues that may be contributing to the seizure that we need to know about. If this is a post-traumatic seizure, then I want to really make sure that I'm not missing anything there. So when are we going to treat the patient? And we're really only going to treat the patient if they're in status epilepticus. And because our treatments all apply the brakes, we're giving GABA agonists. And so our benzodiazepines are GABA agonists, and the ones we have in the pre-hospital setting is midazolam, which is preferred, but also lorazepam and diazepam, or a barbiturate, which is it's an old school seizure medication, but it's something that we'll give for patients in status epilepticus in the ED where these other medications aren't working. So phenobarbital is our big one. And then just the general anti-epileptics of levetiracetam, I can't pronounce that, Keppra, or fosphenytoin, which is Dilantin. And here are the brand names for these two, just so you can have those in your head. So those are the different treatments that we're going to use. Again, Versed is going to be the drug that we're going to apply in the pre-hospital setting. But we only want to treat status epilepticus, and that's defined as a seizure lasting longer than 5 minutes. So if the patient has a seizure in front of you, start the timer, because I don't want to give Versed to that patient if that seizure is going to resolve spontaneously in less than 5 minutes. The other definition of status epilepticus that we treat is the patient has a seizure, they're confused and postictal, and before they return to normal mentation, they have an additional seizure. That one I would also treat. That's technically status epilepticus. Because once we have status epilepticus, that's a different treatment paradigm and workup paradigm in the emergency department. Generally, that patient's going to get admitted for status epilepticus and monitored. But a patient who has a single self-resolving seizure, the vast majority of those patients go home for outpatient follow-up. And certainly if they have epilepsy and they just had a seizure that's the same as their usual seizure and they wake up afterwards, they don't really need very much at all, and usually just the pre-hospital blood sugar and a good story and a good exam and the patient coming back to normal and saying this is just like all my other seizures. This is all I need. I don't need to scan these patients or do even labs on them or anything. We watch them till they're normal, and if they're doing good and it looks like everything's great, we send them home. And because generally they skipped a dose of their medication, so we'll give them an extra dose of Keppra or something like that and get them out. I'd like to do a quick public service announcement. Again, do not give the Versed if the seizure's over. If you drop the Versed, you're ready to give it, and the patient stops seizing, don't give it. Because it's helpful for me to see if the patient seizes again. It's helpful for me to see how long it takes them to return to their baseline, and it's helpful for me to see if that seizure looks like their previous seizures. Once we give a big dose of a benzodiazepine, the patient's going to be much more sedated, There's going to take longer for them to wake up. They may need some, airway management or further workup, or it increases my index of suspicion of bad stuff because I can't tell if it's the Versed or their disease process. They might get a more involved workup than they actually need. So if the patient stops seizing before you give the Versed, go ahead and waste the Versed, or keep it handy in case the patient has another seizure, but don't treat unless that patient is in status epilepticus. And if we're going to treat, here are the doses for midazolam for our ALS providers. We've got our adult pediatric, IV, IO, intranasal, or intramuscular. Intranasal is actually preferred. And so a bunch of different ways we can give this medication. If you have to give more than 2 doses, you got a contact base for that. And if we have drug shortages because the midazolam forests burned down again, we have also the dosing in Denver Metro for Ativan and Valium too, which aren't as preferred, but certainly can be effective in management of seizure. Also, make sure you're checking the blood sugar on these patients once you're doing all the other supportive care. It's helpful for me to rule out hypoglycemia. And the thing that you need to remember is that in good times, it takes me about 45 minutes to an hour to get back a laboratory blood sugar along with the electrolytes and the ED after the patient arrives. We haven't had good times for a long time because we've got staffing issues and flow issues in the hospitals with all the systemic stuff happening in the healthcare system. So if you can tell me the patient's got a good blood sugar because you checked it before you got there, that helps me out a lot because it's one thing I don't have to worry about while the patient's in there and I'm waiting for these labs to come back. It's also something I don't need to go find hands to go and check a blood sugar in the ED. So if it's something you guys are able to do, get that done as part of the protocol, and it's really helpful for me even when it's normal because it takes one bad thing off the list that I have to worry about when I'm dealing with a seizure patient in the ED. So very quick video on seizure, and again, focusing on the BLS approach, which the supportive care is really important, very much key. The treatments are also key, but also being very conservative with our treatments and staying in that lane of only treating the status epilepticus is key. That finishes our video series, or our long video on different neurologic issues. Thank you guys for all you do. If you have comments or feedback, my email's there. And otherwise, keep up the good work, and I hope to see you in person soon.